Hello, everyone. It gives me great pleasure to welcome you to an entirely new initiative by the Young Ophthalmologist Society of India. This series is called Ocular Emergencies, which would be a series of video lectures on the YOSI YouTube channel covering various ocular emergencies. We start off with central retinal artery occlusion. My name is Dr. Anujeet, and I'm a Vitreoretinal Fellow from BBI Foundation, Kolkata. Diving into the etiology of CRAO, it results from a retinal blood flow obstruction, which may be due to an embolus, a thrombus, or vasculitis, which causes retinal vascular inflammation, traumatic vessel wall damage, or spasm. This lack of oxygen delivery to the tissues results in severe vision loss in the area of retinal ischemia. This may be due to an inflammatory disease like giant cell arteritis or SLE, cardiogenic embolism like valvular arrhythmias or congenital defects, hypercoagulable states like protein C and S deficiency, or hematological diseases like leukemia, lymphoma, etc. All this results in a thrombus formation and blockage of the central retinal artery. The blockage of the central retinal artery leads to some characteristic findings in the fundus, like a cherry red spot, arteriolar narrowing, box scarring or cattle trucking, a ground glass retina, and eventually a pale optic disc, which results in permanent decrease in vision. So at the very occurrence of this disease, a patient within the first 24 hours will present with a sudden, painless, profound vision loss, which may be up to perception of light. On examination of these patients, we can see a relative afferent pupillary defect. Our orange reflects from the intact choroid under the thin foveola, contrasting against a pale retina, which is called a cherry red spot. It is there in the figure below. A peripapillary swollen retina, which is opaque due to retinal edema over the next few hours, which can be seen on the OCT on the right-hand side. And over the next few days, the retinal cloudiness and cherry red spot gradually disappear, but the arteries remain attenuated. Late signs include optic atrophy, RP changes, retinal or disc neovascularization, and rubeosis iridis. The aim of primary management is to dislodge the thrombus or the emboli before retinal ischemia sets in, which roughly takes about 4 hours. On careful examination, and if the patient presents in the first 24 hours, and if on examination a thrombus is located, we can go for an ocular massage, which may be done with a gonio lens at the slit lamp, providing gentle pressure for a couple of seconds and then removing it and then providing it again has shown some results in dislodging a thrombus. Anterior chamber paracentesis can also be done at the slit lamp to reduce the intraocular pressure, rebreathing into a paper bag, that is carbogen therapy, pharmacotherapy with topical apraclonidine 1%, timolol 0.5%, or intravenous acetazolamide 500 mg, a transluminal ND-YAG laser embolysis or embolectomy, and thrombolysis may be tried. The further management in the treatment of CRAO are as follows. As mentioned, in the acute stage, it is an attempt to restore the ocular perfusion of the central retinal artery. If presenting in the subacute stage, we try to prevent secondary neovascular complications of the eye. And in long term, we try to prevent other vascular ischemic events of the eye or other end organ damage. So the treatment is highlighted on the right side, while the investigations are as follows. Common risk factors should be evaluated and excluded. Blood pressure, a lipid profile. Investigation with a carotid ultrasound echocardiogram should be done. In young patients, a hypercoagulable state should be assessed for, as well as vascular risk factors, including a vasculitic screen and screening for myeloproliferative diseases. Treatment is mainly aimed at reducing the intraocular pressure, which can be done with acetazolamide, IV mannitol, and topical anti-glaucoma medications. Vasodilation to increase the retinal oxygen content can be done with IV methylprednisolone, sublingual isosorbide dinitrate. And some surgical procedures that I mentioned have been tried, like anterior chamber paracentesis, ocular massage, and ND-YAG embolectomy. This is some data for further reading. I thank you for listening to this lecture. Once again, this is Ocular Emergencies, a YOSI team. If you would like to present an ocular emergency, you can write to us and we would be happy to help you.